we know that transplant can change the natural history of disease in patients with follicular lymphoma. The problem is that in the past, transplants, and well, actually still, transplants are associated with significant morbidity and mortality. We have seen from several allogeneic transplant studies that a proportion of patients, actually the majority of patients that receive allogeneic transplant with follicular lymphoma will achieve durable remissions, potentially cure. The problem is that allogeneic transplant in many patients with follicular lymphoma is associated with an absolute risk of mortality, and that means potentially dying during the transplant. In addition, most transplant studies select patients that are healthy enough to receive transplant, meaning a lot of patients who have relapsed follicular lymphoma will be too old or have too many comorbid conditions to proceed on with allogeneic transplant. We have seen long-term follow-up of several autologous transplant studies recently, and it does suggest that in a select group of patients who receive autologous stem cell transplant, including refractory patients, up to half of them may achieve prolonged remissions. So in my own practice, I think that if a patient has short remissions following chemotherapy, is healthy, I still would consider them for autologous or allogeneic transplant because I think they have the potential, again, to change the natural history of this disease that is marked with recurrent relapses. It's a select group of patients. The treatments are associated with significant toxicity, but in that group who achieves remission, there can be very good outcomes.
The Kronos 1 study showed that patients that were treated with copanlisib had good response rates and a progression-free survival of about 1 year for relapsed and refractory follicular lymphoma. It's a pan-PI3 kinase inhibitor, and it's given IV weekly for 3 weeks. The study looked at treating patients either until disease progression or toxicity. And I think that it has different side effect profile compared to idelalisib, which is a delta PI3 kinase inhibitor. And interestingly, it actually causes elevated blood sugar, hyperglycemia, and hypertension. So it's a very distinct side effect profile compared to idelalisib, and it's also given by vein. So I think that it will perhaps influence the decision of the oncologist as to which, if they have to choose between two PI3 kinase inhibitors, which one are they going to select? Are they going to select idelalisib or are they going to select copanlisib? And I think that that's a decision that needs to be made given the comorbidities of the patient. If a patient has poorly controlled diabetes, perhaps copanlisib may not be the appropriate agent. Or if they have poorly controlled hypertension, copanlisib may not be the appropriate agent. But I think that for third-line follicular lymphoma, we've demonstrated that the two PI3 kinase inhibitors, as well as bendamustine and obinutuzumab, are the FDA-approved choices. But in addition to that, we have a number of different clinical trial opportunities out there for patients to try novel agents.